just seen my greatest claim to fame, my son. But I do have another one, and that is, according to Jean Bousquet, I am one in around 7,000. I'm the person with perennial rhinitis who takes her nasal steroid every single day. And I do that because I know that if I don't take it, I will have problems with colds over the winter, and I will get wheezy, and I'll be ill for quite a long time. And I think we have to convince our patients to do the same thing. Right, why do we need better symptom control? These are my conflicts of interest. Why are we treating rhinitis? Well, we're treating it partly because of the symptoms, but we're also treating it because of those or multimorbidities, because of the complications, the effects on quality of life, and the fact that this is a very costly disease. You know the symptoms. Although rhinitis actually means nasal inflammation, it's clinically defined as a combination of 2 or more of running, blocking, and sneezing itching for more than an hour a day. And you've heard that rhinoconjunctivitis is commonly associated in 50 to 70% of sufferers. And we're talking today about allergic rhinitis, which is the IgE-mediated form of rhinitis. Although, in fact, I think many of you who treat it will agree that non-allergic rhinitis is even more of a challenge. Let's look at those symptoms. As we've heard earlier, nasal congestion in both adults and children is the most bothersome symptom. This is looking at symptom burden, and that is followed by sneezing and runny nose. Why is nasal congestion such a problem? Well, simple. Just try pinching your nose now and holding it closed. If I can't breathe through my nose now, I talk like that. If you hang on to your nose and keep on breathing through your mouth, it rapidly becomes remarkably uncomfortable and difficult. It's even harder when you want to eat, or drink, or smell something, or kiss somebody. A lot of life is troubled if your nose is blocked. And one facet that we've already heard about, when your nose is blocked, it's extremely hard to get a good night's sleep. It's hard to go to sleep. It's hard to stay asleep. It's hard to get down to a restful level of sleep. And the most commonly observed complaints are poor quality of sleep, present in over half of adults and a third of children, snoring, which is probably more troublesome to the sleep partner than to the sufferer, and nocturnal awakenings, which are also frequent. Many patients will tell you that they wake up and they have to have a glass of water because their throat has become so dry because they've been sleeping like Scarlett Johansson, only with their mouth further open. And once you can't sleep, especially if it's a chronic problem, the rest of your life goes downhill. And this is the patient voice allergy survey. You've already seen this, but you can see that in persistent more than intermittent, but in fact in both forms of rhinitis, all sorts of facets of life are very affected, particularly outdoor activities, but also work, sleep, going out, sport, exercise, visiting friends, holiday, indoor activities, public transport. It impacts very, very many aspects of everyday life if you have allergic rhinitis, particularly persistent allergic rhinitis. And the level of these sort of effects on quality of life, as you can see here, are greater than for things like diabetes mellitus or for hypertension. Only depression affects your life more than allergic rhinitis. And just look at the square below this. Look at productivity. 26.8% productivity is affected, compared to 8% with hypertension, 16% with DM. So this is a disease that matters to the individual, and it matters to society. And although complete absenteeism from work is not common in allergic rhinitis, it occurs, it's 3 or 4% in adults and children. What's called presenteeism is really important. The people turn up to work, but they cannot work properly. There's interference with their ability to work. And this shows you some data, not from Europe now, but collected by Connie Catalaris from the Asia-Pacific region. So this is a worldwide phenomenon. We have European data, and now we have Asian-Pacific data. And looking at the different countries, you can see particularly in Australia and the Philippines, productivity is reduced by about 1/3 when patients are symptomatic. And that is absolutely massive, a huge impact on the country's GDP. It's also true, oddly enough, in the UK. And this is UK data showing the similar thing. There's a big variation in the amount of impact on productivity. This is David Price's study. But very few people have no impact, just about 7%. And then the impact goes up. Very few people have 90%, and remarkably few are unable to work. But there's a lot in those middle ranges who go to work and who just do not do as well as they ought to be doing because they've got allergic rhinitis, and probably because they had a poor night's sleep the night before, and for several nights before that. So the actual socio-economic burden is massive. And if you allow unproductivity for 2.3 hours per work day when symptomatic, that costs $593 per person per year. And that is greater than for heart disease, asthma, diabetes, high blood pressure, and respiratory illnesses, all combined. So it is worth spending money on treating allergic rhinitis properly, reducing the symptom burden, improving quality of life, and improving the productivity. But of course, it's not only adults who have allergic rhinitis. We saw from earlier slides how very high it is in the proportion of children and young people. And children and young people in the UK take their major exams in the summer, and they take them just around the time that we have very high counts of grass pollen in the years when the weather is good. And this study shows that those children who have hay fever, seasonal allergic rhinitis with an allergy to grass pollen, are more likely than those without allergies to drop a grade. It was actually in English, maths, and science, compared to their performance in the mock exams in the winter. Now, most children do their mock exams in the winter, they get a B or a C, and they work hard, and in the summer they get an A. These children with hay fever are going from a B or a C in the winter down to a D, because in the summer they cannot concentrate well, they cannot think well, they cannot sleep well. They're troubled by their itchy nose, their runny nose, their blocked nose. The odds ratio for that, if they're symptomatic, is 1.4. If they're taking medication, actually the current medication doesn't make any difference. This was in about 2003. So they weren't taking a combination intranasal preparation. But just look at the bottom column, bottom line. If they were sedating and taking a sedating antihistamine, and in this study 20% of them were taking sedating antihistamines, that odds ratio goes up to 1.7. So old-fashioned sedating antihistamines worsen the psychomotor retardation caused by rhinitis. So never, ever use them in any allergic rhinitis patient. They should be completely prohibited. There's also a social burden. It's embarrassing if you talk a bit like this all the time. People will always ask you, have you got a cold, on the telephone? And if you sneeze, people think you've got a cold and they move away from you on the tube or the bus. Or you sniff all the time. Or you have to blow your nose, or you keep having to pull out a handkerchief from your handbag. There's also a risk for psychological disturbance. Allergic rhinitis is a risk factor for depressive mood in pre-adolescence. And interestingly, it impairs your driving ability. A recent study using grass pollen challenge in allergen-sensitive patients and in controls showed that after a grass pollen allergen challenge, if you look at the standardized deviation of the lateral driving position, which is the degree to which you wobble, the grass pollen challenges worsens that to the same degree as does a glass of wine. If you compound that by taking a sedating antihistamine, you can see that it's likely that allergic rhinitis combined with a sedating antihistamine could easily lead to road accidents. And I think we do not know the extent to which that occurs because we don't investigate it. One other problem that we're hearing a lot about recently, particularly in London and particularly in Oxford Street, London, is pollution. We don't have data on rhinitis and pollution from London, though we should. What we do have, though, is data from Taipei in Taiwan, which is another of the very polluted cities in the world. And you can see from this data that pollution itself increases the rate of allergic rhinitis occurrence. And in this study, when the temperature was over 23 degrees, and there were PM10s, the odd ratio is increased by 1.09. At these temperatures, things like carbon monoxide is perhaps the greatest increase at 1.2. And at lower temperatures, it's still most things increase the likelihood of allergic rhinitis, with the exception of sulfur dioxide in that study. So almost all these pollutants, particularly in that one, ozone at the bottom, increase the symptoms of allergic rhinitis. And in the polluted world we live in, that's a reason for having more symptoms in most patients. You heard a very nice lecture about rhinitis comorbidities, and I'm not going to push this too much, just to say that one should not forget that rhinitis is often not isolated, but is commonly associated with other local comorbidities. And the one that probably matters most is that of asthma. Sorry, I seem to have a little red, oh, there we go, managed to get rid of it. Is asthma, don't worry. And I remember when ARIA was first proposed, John, you could not get the WAO to agree to doing anything on allergic rhinitis until you combined it with the impact on asthma part, when it became obvious that this was something that needed looking into. This, I'm afraid, is the third time you've seen this important graph, but by now you should probably be able to draw it. But it does show you that allergic rhinitis can segue into asthma. And there are nice studies showing that actually if you biopsy the lower airway in patients with allergic rhinitis, already you can find changes. And on allergen exposure, the changes occur not only in the upper, but also in the lower airway. So allergen exposure causes a ripple effect throughout the whole airway. And it's a very important reason in asthma patients to treat that rhinitis, which is associated in 80% of adults. This is the Clatworthy and Price data that shows what happens if you smoke and have asthma. You can see that a current smoker, the odds ratio of poor asthma control is 4.33. But look at what happens if you have significant rhinitis and asthma. The figure is remarkably similar, slightly higher, 4.62. Significant rhinitis means that you're going to the GP, you're saying, I haven't got control, I need some treatment for my rhinitis. The effect on asthma is worse than that of smoking cigarettes. With mild rhinitis, it's still there, it's 2.09, but it's less severe. So presumably, we should be able to show that by treating rhinitis effectively, we can improve asthma control. We have some data pointing towards that. We have the retrospective data Guy showed you. There's a little more data, but we really, really need a good study looking at rhinitis and getting good control and monitoring the effects on asthma. That was an adult study. This is the effect in children. And these are Brazilian children, 75% of whom had allergic rhinitis. They were all adolescents with acute asthma taking inhaled corticosteroids. And the two factors that led them to seek emergency care, one of them was severe persistent asthma, and that had an odds ratio of just over 2. The second factor, in fact the first factor, was the presence of allergic rhinitis with an odds ratio of very close to 3. So allergic rhinitis, poor asthma control, use of the emergency department. And I think we all know that the top 10% of asthma patients, the really poorly controlled ones, use 90% of the costs of asthma. If we can reduce the costs of asthma by effectively treating the upper airway, we're doing each patient a service, but we're also doing our healthcare costs a great service too. So what about treatments? How do they cope with symptoms? Well, until recently, there was no really one treatment which really effectively covered all those symptoms I've been telling you about in the eyes and in the nose. So people were using combinations, but the symptom burden was high. Even in these patients with moderate to severe disease, 96.2% treated, 70% on multiple therapy, most patients remained symptomatic with significant nasal and ocular symptoms, both in mild and in moderate to severe disease. So we weren't treating them very well. And because of that, many patients were using more than one therapy to try and control their disease. And what they wanted was faster nasal effects and improved nasal effects, and faster and improved ocular effects. So that's what they needed. But many of them were dissatisfied with therapy. This is an Italian study looking at what patients were taking. Intranasal steroids, intranasal antihistamine, most of them were taking oral antihistamines, or a few taking other medications. And yet, despite that, 67% were dissatisfied with their therapy. And they tended to be the ones with moderate to severe disease that were most dissatisfied. And that was 77% of those patients. And the factors associated with dissatisfaction were rhinitis severity, comorbidity, very important, and antihistamine use, odds ratio 2.53. Although most patients are treated first with an antihistamine for their rhinitis, they are not particularly effective. They reduce symptoms by 7 to 10% in most studies. The first treatment really should need to be more effective than that. And I would suggest an intranasal steroid as the first treatment for the majority of patients, and a combination intranasally for the very severe patients. Just going back to the Asia Pacific, look at the number of people who believe there is no truly effective allergic rhinitis treatment. 83% in China don't think there's an effective treatment. How many of them are very satisfied with intranasal steroids? Well, what's interesting about this is, again, Australia and the Philippines have the highest, with 50% very satisfied with intranasal steroids. And yet, if you remember, about 30% of each of those were having real problems going to work and reduction in productivity. So maybe, although they were satisfied, they weren't working quite well enough. What we need to know is what patients actually want from their treatment. Because unless we give them what they want, they're probably not going to take it. And I want to explain to you what discrete choice experiments are. Have any of you seen one of these before? What happens with these? They're based on the premise that any goods or service can be described by its characteristics or its attributes. And the extent to which an individual values that goods or service can be described in terms of the levels of these characteristics. And the technique involves presenting individuals with choices, of scenarios described in terms of attributes with different levels. And patients are asked to choose their preferred scenario. And in a lot of these, it's a choice between two different things. So in this study, patients were presented with 7 product characteristics. And you can see what they are here. Maximum symptom relief, and the 3 different levels were mild, moderate, or complete. Time to maximum relief, 3, 7, 14 days. Time to first dose benefit, half an hour, 3 hours, 8 hours. Risk of side effects, administration, frequency, and cost. And patients were asked to imagine that they had to pay the full cost of this medication. And they were presented with 19 pairs of potential allergic rhinitis products based on those above characteristics, like this. And each time they were asked to choose between them. So product A gives you complete relief, but it takes 7 days to work. You feel a bit better 3 hours after the first dose. 10% side effects. It's a tablet you take twice a day, and it'll cost you £15 a month. Would you choose that, or would you choose B, which only gives you mild improvement, takes 14 days to work, time to feel benefit 8 hours, fewer side effects, it's a nasal spray, you take it 3 times a day, and it costs £30 a month. And you can say either A or B, and you're allowed to say neither. What happened when lots and lots of patients were given these 19 different choices? 746 seasonal allergic rhinitis patients were given these choices. What came out of this was that they were willing to pay nearly £44 for complete relief versus mild relief. So it was really, really important to get control of their symptoms. Each hour slower onset, they wanted to pay about £1 less, so they want rapid relief, and 0.62 for each day to maximum symptom relief. So they want something that really works, and they want it to work fast. So my key messages to you are that rhinitis, as you well know, is common. It affects the nose, but it also affects its connections. It reduces work, school ability, and quality of life, and is therefore costly. It worsens asthma. So it deserves very much effective and safe treatment. Thank you very much for listening.